Hello, everyone. I am Rachel Werner, the Executive Director of the Leonard Davis Institute of Health Economics. Welcome to today's seminar, which is on addressing structural racism in Medicaid to promote health equity. We're very excited to host today's seminar on such an important topic and looking forward to the discussion today. So without further ado, I will introduce today's panelists so that we can get started. First, we are joined by Kara James, who is President and CEO of Grantmakers in Health. Prior to that, she was the director of the Office of Minority Health at the Centers for Medicare and Medicaid Services, where she provided leadership focused on reducing disparities and achieving health equity for vulnerable populations. Leighton Koo is professor and director at the Center of Health Policy Research at George Washington University School of Public Health. His research there has focused on Medicaid, CHIP, prevention, and healthcare financing, with an emphasis on strengthening the healthcare safety net. Emma Sando is the Associate Director for Strategy and Planning at North Carolina Medicaid and adjunct professor at Duke University Population Health Sciences Department. She focuses on issues related to Medicaid, including eligibility and enrollment. Previously, she served as the spokesperson for Medicaid and Healthcare.gov at the Centers for Medicare and Medicaid Services, and worked on the Affordable Care Act coordination in the Department of Health and Human Services. Today's panel will be moderated by Athene Venkatramani, who is an assistant professor in the Department of Medical Ethics and Health Policy here at Penn. He is a general internist and a health economist, and he is the director of the Penn Opportunity for Health Lab, which studies life course origins of health and socioeconomic inequality. So thanks everyone for joining us today. And with that, Athene, I will turn it over to you.
Thank you, Rachel, so much, and thanks to all of you for joining us and to our panelists today. Just to set some ideas before we get into our discussion, as you all know, Medicaid is one of the most important, if not the most important, social program in the United States. It's an important component of the safety net with nearly 80 million participants presently. The Medicaid program has been shown to have incredibly large benefits for individuals who participate over the life cycle, right from birth to adulthood and even into the next generation. In addition to its health benefit, it also has numerous economic benefits, with individuals benefiting from Medicaid showing increased economic activity, increased wages, and improved financial security within their households as well. As you all know, the Medicaid program is heterogeneous in many ways. Each state is different at the state level with regards to who's eligible, the enrollment process, the scope of the benefits available, and the different innovations that are pursued to improve the program on various margins. By virtue of the scope of the program, its focus on low-income individuals, and this heterogeneity and this flexibility, there are huge opportunities within the Medicaid program to meaningfully improve health equity, especially as it relates to racial health disparities. That same flexibility, though, may also open the door for forces such as structural racism to actually lead to the divergence of health outcomes across race and ethnic groups. And we're here to really talk about those forces, their role in the Medicaid program, and how we can move forward with Medicaid to achieve a world with health equity. So the first question is for Emma. And this is really to fix ideas for everyone in the audience. In what ways might the design or implementation of the Medicaid program contribute to racial health disparities? And how does this potentially reflect the role of structural racism? Take it away.
Sure. So something that I like to point out to people, and especially my students oftentimes, is that the structure and the design of the Medicaid program really reflects America. The fact that it's a state-run or state-administered program really brings into light a lot of American problems, American issues, and especially race. We've seen that in our country's relationship with race and poverty reflected in things like the implementation of the Affordable Care Act in the 12 remaining states that haven't expanded the Medicaid program. But we also see it in the take-up of Medicaid to begin with. So Medicaid started during the Civil Rights Act era, a time when the Voting Rights Act was just passed, and there was a lot of pushback by Southern states to have a federalized program. So the design of the Medicaid program to be run by the state was in part a compromise with southern states so that they can continue to control the health of their low-income populations, which in the South is predominantly their historically marginalized and Black populations. We've seen that continue throughout the history of the Medicaid program. The very racialized political tool of welfare queens is reflected in Medicaid policy from the 1980s through today. For example, the hesitancy to expand benefits for mothers and families, and the desire to include work requirements and other things like that into the Medicaid program is a reflection of these societal conversations about race and the role of social welfare programs. Even that, you could even argue that is reflected in the 60-day postpartum policy. So Medicaid coverage typically ends 60 days after a birth event. And this has only been lifted in a couple states now as of 2 weeks ago, despite decades of evidence that this policy is a reflection. And that is partly a result of our conversations about race and especially for mothers. But it's really a conversation about priorities. So how a Medicaid program, how a state prioritizes different populations within its Medicaid program, the decisions that are made around clinical policies to keep benefits low in certain states are a reflection of a lot of our conversations about race, such as decisions to add utilization requirements around sickle cell disease or other conditions that primarily affect Black populations, and the difficulties that populations have in even accessing the program because of eligibility requirements. So these are all reflected in the Medicaid program, and can be, the policies that are in place can really be seen to have deteriorating health outcomes over the long haul, because conditions and other decisions that affect Black populations particularly, and other historically marginalized populations are often put on lower priorities unless the state takes the action to act. And we'll get into that in the conversation later, but states definitely can take decisions to reprioritize their policies.
Emma, thanks for that. I really appreciate kind of the full historical scope, both from the origins of the program, the kind of the federalist nature of it, and the possibilities for different choices at various margins of where the program is implemented and delivered as a potential palette for which some of their priorities and some of the structural forces may take hold to either narrow or widen health disparities. So that's just such an incredible introduction, and really appreciate it. So I'm going to turn to Leighton next to, in some sense, get a look at the scorecard. So Leighton, the question for you is, how has Medicaid and Medicaid expansion narrowed racial disparities in coverage or affected racial disparities in coverage? And as a follow-up, are there racial disparities in care received by those who are conditional on being enrolled in Medicaid? And how do some of these disparities we see compare to what we might see in the privately insured population? I know you had some visuals you wanted to show, so I'm going to pull them up right now. And Leighton, you can just tell me to advance when you're ready to advance.
Yeah, you can hold off for a moment. I'll tell you when to go. But so
sure.
Let's just start out. I mean, given that great historical background that Emma said, Medicaid began in the civil rights era. I have always thought of it as a program that was designed as an equalizer. And it's, explicit eligibility criteria are related to income. As far as I know, there are no racial eligibility requirements that are established in Medicaid. Yet nonetheless, because the low-income population tends to be disproportionately Black and brown, it has served to provide much more assistance to Black and Latino Americans. So it's helped a lot. There's certainly a lot of data that has looked specifically at what happened during the recent period of the Medicaid expansions that show those advances that were going on. Again, not perfect. Nothing is ever perfect. And then some of it has to do because some states didn't expand Medicaid, and also because there are continuing restrictions on eligibility that relate to immigrants that disproportionately affect Latinos and Asians. they'll obviously have some implications for Black and white immigrants as well. But so there, the evidence seems pretty clear that Medicaid has improved coverage for racially disadvantaged populations. Where the issue seems to me to have been a little more mysterious, and so I decided to look at this, was what's going on once you're on Medicaid. There have been a number of anecdotal studies that show, and I just had one with a doctoral student recently who showed some disadvantages for Medicaid recipients, in this case for pregnant Medicaid recipients who were getting opioid treatment. She basically found in a dissertation, Black and American Indian pregnant women were getting less opioid treatment care. But anyway, let me, if you don't mind, now you can share the slides that I was talking about. So what I decided to think about was this issue of what do we know about how Medicaid is doing in terms of disparities in some basic parameters of care, but not only how is it happening in Medicaid, but also what happened when you looked at sort of equivalent privately insured individuals and uninsured individuals. And what I saw sort of surprised me. So this slide is basically saying, when we control for a bunch of factors like age, gender, education, health status, and so on and so forth, what are the differences in how many ambulatory healthcare visits, basically how many doctor visits do you get in a year, depending on whether you're privately insured, publicly insured, or uninsured. And what struck me when I looked at the privately insured and the publicly insured is, as far as the difference between Blacks and whites, and just so you know, privately insured white people are the reference groups, or they're essentially scored as the zero, as the baseline. So if you're privately insured, you have, roughly speaking, 2 visits less per year than if you're white privately insured. It's sort of the same if you're publicly insured. If you are Black, you have a little less than 2 visits a year. Actually, if you're Latino and privately insured, you have about 2 visits a year less than white populations. But if you have Medicaid, the publicly insured group, you're about on parity with the publicly insured. And the Asian population, you're doing a little worse with public insurance, roughly on par with private insurance. But no matter whether you have public or private insurance, the differences are stark when you look at the number of ambulatory care visits that people who are uninsured have. So there, depends on what your comparison is. The takeaway that I had from this, and what I'll say is in some of these other slides, which by the way are preliminary and not for citation, is that the sort of the differences that you see, the racial gaps, look pretty similar for publicly and privately insured. So next slide. So now we looked at prescription drug fills. And so here we see a similar sort of thing. There's a Black-white difference. On the privately insured side, if you're Black, you have about a little more than 2 drug fills less per year. If you're Latino, it's about 4 drug fills less. If you're publicly insured, you are getting more drugs in general per year, substantially. But on the other hand, the Black-white difference is still about 3 fills per year. The Latino difference is a little larger. It's about 6 or 7 different. But again, you still see that sort of difference. Again, people who are white doing somewhat better, people who are Black and Latino doing being somewhat lower. And once again, the uninsured just have substantially less access to prescription drugs. Next slide. Here, this is a measure that basically asked people, if you needed specialty care, how easy was it to get specialty care? So here, the measure is basically showing that if you're privately insured and white, and again, that's the reference group, these are odds ratios here, you have better access, or you report better access than if you're Black, Latino, or Asian. If you're publicly insured, you are down from where the white privately insured groups, but actually the level of access at that point is pretty close. It's all sort of middling in around 0.5 to 0.7. So, and once again, if you're uninsured, access is much worse. If you are a Black and uninsured, basically we're seeing an odds ratio of about 8%. So, I mean, a 90% reduction in the odds of having good access to specialty care. So once again, Medicaid looks pretty similar, except for that help advantage for white people in terms of getting access to specialists. But things look better for the people who have private insurance than the people who are uninsured. third slide, and then there are only 5, so we're getting close to the end, is having an emergency room visit. So here what we see is that if you are on Medicaid, you are more likely to have an emergency room visit in a year. There are Black and white levels are pretty similar. Asian, Hispanic levels are a little lower. Asian levels are somewhat lower. The uninsured actually have the odds of emergency room visits that are pretty similar to people who are private insurance. Final slide. So this is a measure of healthcare satisfaction. So this is a question on a 0 to 10-point scale. How would you rate your healthcare? And so what we saw that was sort of interesting was actually both in the privately insured and the publicly insured group, Blacks were somewhat more likely to say they were satisfied. Hispanics were somewhat more likely to say they were satisfied. The difference for Blacks was not significantly significant for the public group, but was still higher for the Latinos. And again, generally much higher, whether you're privately insured or publicly insured, compared to the uninsured Black and white statistics. Nonetheless, I will note, given that this is a 10-point scale, these differences of, maybe a third of a point are pretty modest. They're modest differences in how people are assessing their satisfaction. So that's it for the slides. And so now the point that I take from this is, yes, there are differences that exist in access to care and satisfaction that occur between Black and white populations in Medicaid, with Latino and Asian populations, but the differences are pretty similar to what's happening in the private sector, which tells me that it's not necessarily Medicaid per se that is causing some of these gaps. It's more structural problems, whether it's in society or how the healthcare system is set up. That is the lack of availability of providers in certain areas of town where, depending on the racial composition, the extent to which there are fewer Black or Latino doctors. Also, sort of broader social problems that have to do with the history of discrimination and mistrust and other social factors. So yes, there are some differences in Medicaid. Things could be improved, but part of it is there are also some underlying problems that affect both the publicly insured and the privately insured group. On the other hand, if the question is, how is it compared to being uninsured? No question about it. You would be more satisfied, you would have more access to care. I realize these weren't causal studies, but you'd be better off if you have insurance, whether public insurance like Medicaid or private insurance than if you're uninsured. So helping out the states where there's no Medicaid expansion or the immigrants who don't have any access at all in Medicaid would help those populations.
Absolutely. Thank you so much, Leighton, for that. So I think we've gone from Emma's kind of broad sweep and kind of the outline of all of the different margins of change in Medicaid and where there may be opportunities for improvement or opportunities for further divergence in health outcomes. We've kind of gotten a rich empirical picture of various aspects of care conditional on being in the Medicaid program from Leighton, so a scorecard of sorts. And so now we turn to Kara, who has a very unique seat looking at the Medicaid program. And so Kara, the question for you relates to the regulatory levers that the federal government side has in terms of addressing structural racism that may exist in the Medicaid program. What kinds of things have been tried from the federal side, and what's worked and what hasn't?
Yeah, well, thank you so much, Athene, for inviting me to be part of this conversation. It's great to join Emma and Leighton in this. And I think one of the things I just want to go back to that Emma mentioned in her framing of this is that, the states have a lot of the power and their ability to make changes to the program. So at the end of the day, we're left with where you live matters for a lot of this. And it is a program that the federal government can do some things, but it really is ultimately up to the state. So when we think about what's been tried and what's been done, of course, we're talking about from the regulatory space. And as Leighton mentioned, Medicaid is critical to access to care compared to those who are uninsured. But in many of those slides, he also showed, sort of privately insured fares a bit better in some cases than those with Medicaid. So we have that sort of structural inequity that I would say that we need to encourage Congress to address some of the structural issues that maybe put Medicaid on a different footing than some of our other health insurance programs. But in terms of, drilling down within that to what is HHS and the federal government doing in terms of their regulatory space, we think about, sort of rulemaking. We talk about guidance and, demonstrations and grants programs. We have payment models. We have quality improvement. Of course, there are the state waivers and state plan amendments that individual, states can submit, and our, Medicaid scorecard as we look at quality. So kind of thinking about each of those a little bit differently, there's flexibility and obviously options in there. So we can look at the contracts. We can, sort of put rules and kind of regulations within the contracts of what we're looking for that talk about accessibility, networks, those sorts of things. We can also, and we have seen state Medicaid director letters that have gone out to help educate states about what the flexibilities are that already exist, some of which they may or may not be aware of. So we think about, we mentioned earlier opioids and sort of what is flexible there. There was one that was put out last year on social determinants of health and how states can leverage the Medicaid program to address the social determinants of health. We also look at, sort of the FMAP and sort of encouraging states through some of those resources that can come through to support things like upgrading technology and infrastructure to be able to capture better data to understand what's happening, or language access services and sort of looking at reimbursement for those are some of the things that have been tried. And then what we see is that it's, the states are on a continuum. You've got leading states who are doing really innovative and interesting work and really kind of working to improve access and outcomes. You have those who are trying to figure it out and struggling a little bit more. And then we have some others who may need a little bit more encouragement. Unfortunately, some of those that need a little bit more encouragement, when you start looking at the map and looking at some of the racial disparities, they are those states that disproportionately have larger shares of communities of color in them. And so I think, thinking about how we move forward, and we're going to kind of get into this a little bit more, I think about how do we support those who are at the front of it? How do we help provide services for those in the middle? And how do we push those who are kind of lagging behind? And I think when we look at that, I think that's kind of reflective of what you've seen of the pickup of states who've been able to take advantage of some things, others who just regardless have not. And I think one of the other things that we haven't touched on that's just important for everyone to remember is states have to balance their budget. So there's a finite set of resources at the end of the day that you're working with. So even with additional FMAPs or partnerships, there are some outlays that states are going to have to do that they are, again, going back to those trade-offs that Emma's talking about, they may not be able to make that trade-off to get the resources they need.
Fantastic. Thank you for providing that overview and kind of some of the specific types of regulatory levers that the federal government has, and also pointing out the kind of where the power, a lot of the power is with the states to make these discretionary changes. I want to zoom out a bit, and as part of this, I'm going to ask Emma actually to zoom in her experience in North Carolina. But let's just take a step back. We're hearing this term a lot, anti-racism, that has a specific definition from the work of Dr. Kendi and so forth. But in applied to organizations, I often don't understand what the goal is. So my question to you all is, what do you think it would mean for the Medicaid program to be anti-racist? And how would you measure progress in that regard? And how far do you think we are from that? And maybe I'll start with you, Emma. And as part of your answer, you might tell us some of the really interesting things you all are doing in North Carolina with regards to this particular question.
Sure. So Medicaid really has the tools available to be a leader in improving health equity and being an anti-racist program. The fact that we serve disproportionately larger historically marginalized populations means that we are well suited to be leaders in this area. We have the flexibility. That's oftentimes something that people don't understand about Medicaid. So I'll reiterate this point. Medicaid is an extremely flexible program. It's also the most complicated and not easy to be flexible, but working with our federal partners, we have the ability to do things outside of the box, much more so than other health insurance programs in our country, because we not only have the federal flexibilities, but we can do things if state funds are available, which they often aren't, to go above and beyond. And we've done a number of things in North Carolina. We specifically put out dollars to primary care providers that specifically serve disproportionately high historically marginalized populations in our state. We did this based on census tract data, poverty levels in the state, and found that there are providers that disproportionately really do serve really high poverty areas. And in North Carolina, that equates to very high minority populations as well. And so we gave these practices dollars and gave them flexibility to use these dollars to specifically address health equity in their practices. So if their practice needed better data infrastructure to address the problems that are going on in their practice, or if their practice really needed a food bank because a lot of their kids that are coming in are suffering from food insecurity, we can provide those tools through the Medicaid program. I don't want to play the North Carolina Medicaid staffer here, but we also have an amazing program called Healthy Opportunities, a first in the nation pilot program that will be providing social determinants of health related services to our Medicaid beneficiaries. So providing housing insecurity needs assistance, food insecurity needs, domestic violence needs that beneficiaries need, and transportation related services, because we know that oftentimes those non-medical drivers of health go hand in hand with the needs of our population, and specifically the needs of our historically marginalized populations in the state. So that is an area of focus that we really, really want. Just to step back, that Medicaid also has the market power. A lot of people don't really fully appreciate this about the Medicaid program, but if Medicaid were to go away tomorrow, there would be a lot of providers and hospitals that would not be financially stable because Medicaid does fund so many services. So if we can require our providers to act in certain ways, or make inroads to those that we serve, we can really make a huge change, not only for Medicaid providers and the Medicaid beneficiaries that they serve, but also other insurance providers look to the Medicaid program when designing policies, and our policies can be reflected in the private market. People often don't think that that is the case, but it can be the case. And if Medicaid is innovative enough, we can spread this innovation across other payers as well. Lastly, Medicaid is an employer, and we do employ are the most prominent payer for direct care workers. And this is an area that I know has been getting a lot more attention lately, but direct care workers are disproportionately immigrant from historically marginalized populations, women who, if we were to be the model employer, could seriously improve the health of this very large population of workers in the country, and the employment conditions in which they serve.
Emma, thanks for that. One of the things that I wanted to reflect on in your answer that you're doing in North Carolina is kind of this more sort of universalist approach of targeting areas with greatest need, which which would benefit people regardless of race and ethnic background, but may actually deal with the fact that the structural racism leads to kind of these disproportionate representation in communities that have more social determinants of health needs than others. So that's a really interesting approach that you have there. So let me
say
yeah,
that we
please.
also are significantly increasing our pay for our direct care workers, which is one of the things we are doing. I'm not just saying that we should do this, we are doing it in North Carolina as well.
That's fantastic. Recognizing that a lot of the healthcare workforce working in that position tends to be women from underrepresented minority groups. So that's a fantastic policy there. So Leighton, I'll turn to you. So what do you think it would mean for the Medicaid program to be anti-racist, and how would we measure that? I think you're muted there. All right.
I think in general, from its roots, Medicaid tries to be an anti-racist program, but does not always succeed. So the things that Emma was citing are great examples of things that could be done. And to the extent that states aren't trying some of those innovative ideas, I encourage them to think about them. On the other hand, the point that I think I would take from some of the analyses that I did, if we have a situation where we see some of those same inequities occurring in the private insurance world, then it makes me think Medicaid in and of itself would have difficulty doing some of those things when they're sort of more systemic, which doesn't mean Medicaid can't try. And again, it's not just the Medicaid agencies. Medicaid in so many cases is working through managed care plans, and those same managed care plans are also touching people in Medicare, private insurance, et cetera. So there is that ability to sort of try to do motivation to pay attention to these things. I guess the other thought that I had from some of my analyses is there are certain areas where we know Medicaid has a really disproportionately large role in the healthcare sector. So for example, care for people with disabilities, long-term care, maternity and prenatal care. Medicaid is a heavy hitter in these areas. Provision of a lot of behavioral care. Medicaid is a larger player than private insurance and the private sector in general in many of these areas. And so that's where it's worth, to me, thinking, is there something unique that Medicaid can do? So some of the expansions, for example, in postpartum care, some of the efforts to sort of increase sort of services in the maternity spectrum to help try to deal with maternity mortality problems, that's targeting an area where Medicaid has a disproportionate role. And so we can see whether it's possible to look for some of those disparities in some of those areas where Medicaid has a bigger role, and can they do something? But in some cases, we don't know. I mean, I was recently talking to a long-term care expert about what do we know about sort of health inequities within long-term care or within nursing homes. And the answer is it wasn't clear that people know very much about what's going on. That has not been an area that people have looked at very much. So that's where, again, there are things maybe that researchers like me, there's more work for stuff like for people like me, or for you, Athene, to do in these areas. But more than that, to sort of try to have for people who are program administrators or people who are trying to stimulate change like Kara to sort of work in that area.
Fantastic, thank you. Kara, I'm curious what you think.
Yeah, so I think there's a lot of things. I think one of the things is, when we're talking about structural racism and being anti-racist, these are deep-seated and pervasive issues that go back and have an intersection of, when we talk about social determinants of health, we talk about the intersection of income, race, and how it plays out. So looking at that, and then the beliefs. So to me, and Emma touched on this in her comments early on in the framing of this, Medicaid is a program that has strong beliefs about who is deserving of being on the program, what they deserve for getting that. And I would say, one of the things I would love to see in a Medicaid as an anti-racist and addressing that structural racism is that we have changed the narrative around Medicaid as a program that is really serving, as Leighton mentioned, some really vulnerable populations who are very deserving of services, high quality services, and what we should. And so I think restructuring the narrative that we have around Medicaid is really important to us really addressing the structural racism and having it be an anti-racist program. I think the other thing, when I look at some of the outcomes that we see, we talk about access and how Medicaid is leveraging that power of the purse to make sure that people have access to services that they don't have to. When we think about, and Emma mentioned the importance that Medicaid plays in those places where we haven't seen the Medicaid expansion, we've seen more rural hospitals close. They are more reliant on Medicaid and Medicare. And so that loss of dollars, what that means for those individuals living in those rural communities, how far they're having to travel to get care, whether or not there's emergency services, those sorts of things. The other thing that I think when I look at going back to that intersection and the deep-seated policies, Medicaid has an opportunity and does already touches so many of our human and social service programs. When we think about SNAP, WIC, housing, TANF, all of those pieces, yet they're not necessarily integrated as well to allow us that flexibility. And I would love to see sort of Medicaid looking a little bit more at that ability to integrate and strengthen those collaborations and opportunities to really provide whole systemic care for individuals and their needs. When we think about our, going back to technology, our human system services systems don't talk to our health systems. So how do we start to look at that and track individuals and provide some of that, and having Medicaid use that power to be able to do that a little bit more and push for some of that change again at the states, which would help all of those dollars go a little bit further in our limited resources. But I think, again, narrative change just really critical. Medicaid is an extremely efficient and effective program for the few dollars it has, but I think we need to rethink whether or not that's what we should really be focusing on in terms of reduction of costs and things, as opposed to outcomes for those who really need support and services.
Thank you so much, Kara. That's incredibly enlightening for me, actually, kind of the way that you've sort of painted what the goal should be and kind of some of the different routes to get there. On that point about goal setting, there was a question that came up in the chat from Kimberly Brown. So oftentimes when we do work in health disparities, even on the research side, the benchmarking involves the use of non-Hispanic white populations as some kind of reference groups. Kimberly points out that there may be a danger in doing that because it centers white people potentially in this in policy questions and in this work. And so the question is, are there other ways to generate meaningful comparisons or meaningful metrics or ways to track our progress in equity that doesn't necessarily make that choice of a referent? So any one of you can jump in, and curious what you think there.
Sure, so I can address this in part. I'm guilty for this because my slides explicitly use privately insured white people as the reference group. And I'll say part of that is, as a statistician and a methodologist, is the convenience of trying to choose a large group that you have as your reference group that makes your results somewhat stabler. Actually, what I tried to do, by the virtue to me of those slides that I present, is actually you can compare across anyway. So the choosing the white people, privately insured people as a reference group is for determining significance. But you can look across the slides and relatively quickly see who you're comparing to. So if you want to say, gee, I care about publicly insured Black or Latino people, and that's my reference group, that same set of slides will let you see those comparisons. Now, it's a fair question, is race the meaningful measure? And there are lots of people, and there are deep questions about what does race mean? Is it really biological? Is it cultural? What about the fact that Latinos and Asians and even Blacks and whites, there are many subgroups within them, and should we use those? And all those are valid and reasonable points. But at least in the US, we generally have thought of those basic racial categories as having some meaningfulness. They're not perfect. But that's why we do those things. And part of the problem also, I'll say, is to get a little more disaggregation requires much bigger data sets than are relatively available. But you're right, it shouldn't all be white centric. It should be, who can you compare meaningfully? And I hope that we can set it up that way. And I tried to actually have my slides do that, but it's when you do these regression models, you actually do have to leave one group. I tell my students this all the time, and you just have to do that for statistical reasons, and that's what I chose to do in those analyses.
Appreciate that, and that's a choice I think on the research side we all make. Kara, I think you wanted to jump in on this one, or?
Yeah, just real quickly on that. I think one of the other things, and it is also, as Leighton mentioned, there's the statistics. There's also kind of a convenience of ease of comparison, because if you're bouncing between, and we've looked at, do you compare to the group that is performing the worst or the best, which varies when you look at different outcomes, access, and things like that. It's easier, I think, sometimes for people to understand than it is if you're looking at, well, in this group, we're comparing to Asians because they have better outcomes. And then in this one, we're comparing to non-Hispanic whites. And in this one, we're comparing to Hispanics. It becomes a little bit confusing. So there is a simplicity to that. I think the other point that is really important for us to lift up is that, and something I forgot when I think about, Medicaid as an anti-racist program, is we would actually have insight into different populations and population groups. We don't have data, very, very good data for those who are American Indian, Alaska Native. We don't have very good data for, Asian as compared to Native Hawaiian and other Pacific Islander, which are different. And we would have that ability to look at what's happening, to be able to understand where people have different challenges. And that's something we have to really figure out, how do we solve that? Because it's not going to get any better. We are becoming more diverse in our society. And I think as we think about what that looks like, again, going to that intersection, we have to do a better job, because even just, the census just put out data on poverty rates, and their poverty report doesn't include American Indian, Alaska Native in there. And it's, again, sample size issues, but how do we really start to have that insight to understand what's happening in different populations?
Thank you. I wanted to actually switch gears to a question from Jamila Missioner. So this question is, how do you think about payment reform as a mechanism for addressing structural racism? And so Medicaid, which is a program that disproportionately serves large shares of people of color, has lower reimbursement rates than other types of private insurance. And so do you view this reimbursement rate question as a channel by which structural racism, via devaluing potentially the lives of racial and economically marginalized people, as one potential wedge that creates potential health disparities? And if so, what are the policy options that you might have for addressing this? So anyone can jump in on this one as well.
I just want to start by saying that this is a really, really important question that we haven't spent nearly enough time on addressing as a research community. And I love that the March Health Affairs issue had a couple papers focused in this area, but would love more conversation on this, as there's been such a big effort to move towards value-based care, and without really looking at what potentially the implications of that would be for disparities and addressing health equity, and the way that it can be designed could further some of these access issues, and really bring further light into what people aren't even really seeing with the data yet. And so I worry about this almost every day. It keeps me up at night. And I wish I knew all of the answers, other than we need to do a lot more thinking and a lot more data analysis before implementing the newest and greatest models that are supposed to save money for the system and whatnot. Medicaid does not nearly reimburse enough, but it really also, like everything with Medicaid, it's complicated. So it depends on what you are focusing on. In some areas, Medicaid is a very good payer, and primary care is often brought up as the showing that Medicaid isn't paying enough. But if you look in some other areas, Medicaid does pay more than Medicare, or other things like that. So it's a very complicated area once you start getting into Medicaid reimbursement policy. But what Medicaid programs can do is really look at where our beneficiaries are seeing greater health inequities, and whether we can drive increased reimbursement into those areas to incentivize providers to pay more attention to increasing the services that we want to be increased, and potentially reducing the services that are not value added. And for example, in North Carolina, we greatly increased our vaccination rates or reimbursement rates above and beyond the Medicare or private insurance rates. And specifically that was done to increase the rates amongst Medicaid beneficiaries of COVID vaccination. And we can take those lessons. There's so many lessons from COVID that we have learned about how to address health disparities that we can take into other aspects of the program that don't have the lights shined on them that COVID does.
And
So,
I would
thank you
just,
for that. Please.
I was just gonna say, just adding on that, because I think Emma highlighted a lot of things that are really spot on. And I think payment can be used definitely for that. Again, that sort of balancing the budget. If you're increasing payment and reimbursement over here, you're pulling a little from somewhere else over here. So what is that, seesaw? How do you get that balance act? And then I think in terms of the value-based payment, that is also an opportunity, but it also is, there's a lot of lessons that I think CMMI has in terms of what participation and how you get people to participate in those programs. There are also challenges for those that some places don't have a lot of waste to say in there to be able to pull out to put those upfront costs. So how do you create the on-ramps that allow for more participation for different types of providers? When we're looking at some of the CMMI models, ultimately, it's a numbers game. So you have to have a certain amount of beneficiaries in your program in order to be able to participate, which means a lot of rural providers, those are smaller, don't have that ability. So how do we create some of those flexibilities, understand that there may be more upfront costs that are needed in order for them to participate in the programs and in those models, and think about it. But payment actually can be used. And I think, how do we think about health equity in our payments in a way is also really important. And I know that's something that the administration is kind of struggling with and trying to think through, how do you incorporate that in there? Because those incentives do matter in terms of outcomes and access.
Thank you.
What I wanted to say is, when I've heard people talk about that Medicaid might have a problem, and one of the number one things people keep mentioning is that Medicaid payment rates tend to be very low. And because of this, we know that there are a relatively large proportion of doctors who say they won't see Medicaid patients, or they limit the number of Medicaid patients that we see. And yet, when we look at the data, actually sort of the level of ambulatory care visits, even controlling for health status that privately insured patients and publicly insured patients get, is pretty similar. So if the difference is that doctors aren't willing to see Medicaid patients, then what is it that's getting Medicaid up to similar levels of utilization? And my guess is that the thing that Medicaid has on its plus side is very limited cost sharing. So private insurance, typically speaking, has fairly high cost sharing, particularly for a lot of low-income people. If they're in high deductible health plans, basically that may mean that their first $1,000, $2,000 of care is all out of pocket. Medicaid has, copays that are extremely limited, typically, maybe $4 or less, in many cases free. And so that helps to boost access in Medicaid. The other thing that actually plays a big difference to help in Medicaid is the existence of the safety net providers, places like community health centers. But so to me, I think we can and should think about payment reforms and payment levels. On the other hand, it's not just what the payment rate is. Part of it may also be the conditions of payment. So things like, what do we know about cost sharing? So again, this is one of the real blessings of Medicaid, is the low cost sharing. When we've done analyses, the really distinctive thing that happens for Medicaid is people who are on Medicaid have much lower cost sharing burdens, out-of-pocket burdens, which makes sense because they're poor people. So they have less to spend. The other thing I'll say that when we've looked at rates a little more closely, in fact, people say that private rates are a lot higher than Medicaid rates. I'd say it's a little more complicated. That in fact, much of the difference actually has to do with the cost sharing levels. So let's think about a service that you might think in private insurance, they say the nominal amount we'll pay is $100. However, the consumer is responsible for 20 to 25% of that. So what that means, the insurance company is only paying $75 or $80. Medicaid in many cases maybe is paying $75. So maybe it's actually the amount of the Medicaid reimburses to the provider is basically about the same. And the difference then is that cost sharing level. But we understand because the Medicaid recipients are poor, we don't want to have them have high cost sharing burdens. There's lots and lots of research. If anything that's clear in health services research is that cost sharing burdens have a very heavy effect, particularly for disproportionately poor people. So it's how you balance that out. And I think in that regard, that's one of the other elements we need to think about is how can we improve the access to care among the people who have it? Other payment experiments like the thing where Emma was talking about trying to add in extra funding to providers in areas where there is a high density of poor or marginalized populations. That's an interesting example that I haven't seen other people. That'd be an interesting experiment to try to see if that works. But Kara is also correct that to the extent that traditionally we think of Medicaid reimbursement rates as being kind of low, a lot of the sort of value-based payment methods that we have really sort of assume we can squeeze out a little bit that excess in one area to sort of pump up another area. But Medicaid starting out sort of close to the bone to begin with, so there's sort of less to squeeze.
Yeah, thank you all for that. It's really it was a great question and a really incredible and rich set of answers. And the answer, I like what Emma said, which is that it's complicated and there are lots of trade-offs that need to be weighed. So Kimberly Brown has a number of comments in the chat that kind of follow, Lauren Murray has a number of comments from the chat that kind of follow from an experience she had while on Medicaid. And a lot of her comments have to do with administrative burdens in the program. So difficulties in getting access, navigating the program was confusing, even for someone health literate like her, and there's stigma related to the program. And we know from some of the work that Pamela Hurd and Don Moynihan have elevated that administrative burdens can both reduce participation programs in general and potentially widen racial disparities in participation. So I was curious about what any thoughts you might have of how Medicaid can become more user-friendly.
I think the Affordable Care Act made quite a significant change that not a lot of people talk about, in that simplified Medicaid application was a requirement of the Affordable Care Act, whether or not you took up Medicaid expansion. It was not a optional change, and this has set a federal standard of what can be asked in the Medicaid application process, and has significantly eased the application process which is number one. You can't do anything until you get in the door. And now that it has been 12 years since the passage of the Affordable Care Act, I think that there needs to be another look at that application process. A paper application is where a lot of beneficiaries still come in the door, but it is also 2022, and there needs to be a greater emphasis on making the process as it is for 2022, user-friendly and available in digital formats very easily. So we can definitely make improvements to getting people in the door. That key, getting your card for the first time is the foremost, and oftentimes the experience that people have most most directly with the Medicaid program, and your experience with your individual provider may vary, and it really depends on the provider, but your experience with the Medicaid program often is through the application process. So that really is where I think a lot of states should focus, where the federal government should focus on improving access so that we reduce barriers, stigma, and make the program welcoming to people. This I, as a person who studies southern states and lives in one, I can tell you that will face significant barriers politically, and but it is a fight worth pursuing to make the program more open to beneficiaries.
Fantastic. We have a few minutes left and we're going to have to wrap up. I have to say, of all the sessions that I've moderated, there have been the most questions coming in through the chat in this one. We weren't able to really get to all of them, but if there's any questions that you see that are of interest to you, you all can feel free while you're contemplating this next question to answer it. So here's the last question before we wrap up, and we can start with Kara, then go to Leighton, and then finish with you, Emma. So you have 5 minutes with the President of the United States, Secretary of HHS, and the CMS Administrator. What would you tell them in that 5 minutes about addressing structural racism in Medicaid? What is your wish list, or what is the thing you put on the agenda? Kara, if we can start with you.
So 5 minutes is not a lot of time. I would say that one of the things, fix the data. So we actually know what's going on and can track it, to work to reframe the Medicaid narrative so that we can garner more support for this program and the great work that it does. Don't be afraid to push the states, particularly those who are lagging, and use that power to move them along. Strengthen ties between human services and HHS, because they really are, as Leighton talked about, touching so many of our vulnerable populations and a lot of intersection. Embed equity incentives into all rules, quality improvement, payments, options. And lastly, something we didn't talk a lot about, work on the workforce. We have a real healthcare workforce problem in our country that is not getting any national attention, really, in a way that we need to have a sustained and long-term plan for addressing our health workforce needs. That is comprehensive. So go back to that workforce commission that never got off the ground in the Affordable Care Act, and let's lift that up and get the people we need care.
Wonderful, thank you. Leighton, what about you?
So one of the most important things is try to get Medicaid expansion in all the states. The Biden administration and HHS have been trying to do that. There are all sorts of reasons why that has been politically difficult, but that remains one of the single easiest things, or I wouldn't say easiest, important things that would help. The other thing that I warn about is this notion that we all are increasingly aware of: when the public health emergency ends, the Medicaid moratorium on disenrollment will end, and we will expect to see over the year after that very large reductions in Medicaid enrollment, somewhere on the order of, maybe if we're lucky and conservative, it's only 15 million people. It could be way worse. And so part of where I hope that HHS and states are extremely careful about is sort of making sure that there's planning for it, that there's adequate resources, and frankly, that CMS is monitoring what is going on in the states and trying to sort of be prepared to step in if they see enrollment systems breaking down, which is entirely conceivable over the next year. That can have massive havoc. And it's something that many people who are Medicaid cognoscenti are aware of, but is there that awareness at a larger level that we are standing on the brink of, millions and millions of people losing health insurance coverage, maybe many of the gains that we had under the Affordable Care Act disappearing because of the potential havoc when the Medicaid unwinding, as it's now being called, begins.
That's a great point. Emma, take us home. Your 5 minutes.
I would point them to Kara and Leighton's 5 minutes and say, do all of those things, but also fund them, please. Give states the money to be able to do those things, especially connecting systems and IT improvements and infrastructure, but also give states the flexibility to, if the goal is to improve the beneficiary experience, improve health equity, then we need to be able to have the flexibility to do that by the federal government. Lastly, we need to focus more on LTSS and home and community-based services, because those are an area that we see significant health disparities and we don't even know what all of them are.
Great. Thank you all for that. I think Rachel's going to come on and wrap us up here.
Thank you, Athene, and thank you, Emma, Kara, and Leighton. That was such a fabulous discussion and an important one to have. So I appreciate you all spending some time here with us today. And Athene, thanks for the great moderation. And thanks for the audience. You guys had a great audience out there today, a big audience with lots of questions. So thanks for participating. I want to remind you that about a month from now, we are going to be hosting our next big virtual event where we will be hosting Congresswoman Lauren Underwood in conversation with Tony Viruel, the Dean of Penn Nursing. So Congresswoman Underwood is coming from the 14th District of Illinois to talk hopefully about, I think, maternal health, given her focus there. And I imagine some of the conversation we started today will continue next month. So please join us then. Thanks again for joining us today.